advancements in orthopedic medicine, please welcome Dr. Thomas Knox.
Thank you. So, as Ron mentioned, this project that we are now doing at Baxter started about 3 years ago. And I want to say that robotic surgery for orthopedics is an evolving process. And it started probably about 10 to 12 years ago. I enthusiastically came back after I saw this system that we're using and presented it to Ron, and eventually it went to the board of directors. It went to the other orthopedic surgeons in the community, and there was some hem and haw back and forth about what we want to do. Anyway, first of this year, here we are. All 6 orthopedic surgeons in this community are using the CORI system, the current system we have. And as an overview, what does this system do? Robotic surgery has been something that you, before on all other systems, requires getting a CT scan or an MRI, and then that goes to the respective factory of the manufacturer of that device. Their engineers look at that data and then send you back a plan. What intrigued me about the system that we have, and I might add, this system has now been adopted by the Hospital for Special Surgery in New York City, which is the #1 orthopedic hospital in this country, is that it allows us to collect real-time data interoperatively, which takes about 15 minutes to do a process we call registration, where we can locate the center of the knee in the joint, the center of rotation of the knee through the hip, the anatomic axis of the ankle joint. That all feeds into the computer, and then we map out, do a 3-dimensional mapping with a light pin that gives us an actual 3-dimensional rendering of the knee. From that, it gives us an idea of the size of the implant we want to use. But more than that, it also allows us to look at the soft tissue balance, because everybody's knee is a little different in terms of how you walk, how you get about, and what the soft tissue balance is. And heretofore, with standard instrumentation on total knees, you take a knee and you make it fit the joint. We're now making the knee, using the knee, our regular knee replacements. We actually are able to fit them in the joint by rotation adjustments that can be done to 1/2 to 1/10 of a degree, distal resection, how we tilt the prosthesis in place, and how much resection we're doing on the bone. So, let's just see here. This is the actual system, and it consists of the device on the top, which is electro-optical, and that feeds in with little paddles that we implant on the patient. We put pins in the tibia and the femur. We attach these paddles, which are recognized through this camera system, and allows us to do the data manipulation. So it was originally developed at the Carnegie Mellon Institute, Pittsburgh, and it evolved as a planning tool, and then evolved through several enhancements with the addition of a computer-controlled milling device for actually preparing the bone surfaces. As I say, it's unique compared to other robotic knee systems. It allows us to use a soft tissue tensioner, which is a device we can put into the joint. I've got a little video on that in a minute, to allow us to judge the patient's soft tissue balance, both medial and lateral. And as we put our total knee in many cases, probably 85% of the time, maybe 90%, we don't have to do soft tissue releases now, because the joint is balanced by the way we put the joint in. So it allows us to assess implant sizing, 3-dimensional positioning of the implants. So we can now match the implants to the patient and not vice versa. So at the beginning of the case, we put pins into the femur and tibia, adapter paddles, anatomic landmarks, as I mentioned, and then painting of the joint surface to create a 3-dimensional rendering. This is the device that we use to actually do the painting. On the knee, the little probe you see there at the end, and we point these little paddles to the camera, which recognizes all of it. If it sounds like rocket science, I think it is. The ligament assessment is then accomplished with a proprietary device that is unique to the CORI system. It's not necessary to use this. I use it, and some of the other surgeons do as well. But it also then integrates itself into the patient's operative plan. So that this is real time. The main thing is that this is real time data, and it's not a plan that was developed at a plant by an engineer. But so we're actually doing this for the patient. Three-dimensional, rotational, distal resection. This is the milling device that will only extend for milling to reset the appropriate amount of bone. It won't work if you're off axis on any parameter whatsoever. So we can typically get our correction within 1/10 of a degree as far as our operative plan. And that's highly accurate considering any type of MRI plan knee where you're using cutting tip length. If you're within a degree or 2 degrees, you're in pretty good shape. In fact, at one point, I think Washington University presented a series where they felt like standard operative planning was probably about as accurate as custom-made templates. So, consider this. There are no bone cuts have been made during this planning process. Everything is totally planned out without any preparation on the patient other than operative exposure. And it's dynamic and it can be changed according to the surgeon preference. No outside MRI, CT scans, or factory-generated plans are required. The burr bits, I think, are probably $350, I think somewhere in that neighborhood, which are for each case. Whereas an MRI scan is a minimum of $400, and typically the operative plans are another $500. So it's a net savings for the patient and the hospital, particularly the patient, of at least $1,000 per case. Much more accurate assessment of individual anatomy, and once again, reduce patient costs. So, this is a short video of the case I did recently, and this is I'm using the soft tissue tensioner as the final point of my preparation for this case.
All right, go right ahead.
We put this in, and we're looking simultaneously at the screen.
Once you get it in that, there you go, that green section,
we are,
that's the green perfect amount of pressure there.
We're going to put this knee through range of motion. These are the paddles, the optical paddles that you're looking at. The little bars you see down here are balance points created throughout range of motion. Going to the lateral joint, assessing the lateral ligament complex as far as soft tissue balance. I remind you while we're doing this computer is collecting all of this data with the previous information we put in to calculate an operating plan for the positioning of these implants. On the next slide,
All right, go right ahead.
let's see here.
Yeah.
Once you get it in that, there you go.
Let's see.
We'll go full range of motion, non-stress, and then I'll tell you that we're moving on to the next screen, and we'll we'll
At this
just
point
have
in the
you feel it,
operation, we
right?
have
Okay,
the
so range of
trial
motion here.
implants in. We're putting them through range of motion. And I want you to pay attention to the screen
Okay.
here where we're doing this.
It looks
And they're going
awesome.
to show our soft tissue
And
balance.
then here, we're gonna have you just hand stress. Tilt that femoral array up just a little bit for, there we go.
Just in